Welcome to another episode of Clear Lake Connections. This is where we get to hear from the people behind the businesses in Bay Area, Houston. This is proudly sponsored by UTMB Health. Today we're super excited because we have Dr. Kalia here with UTMB Health. Before we get into what you're doing exactly that we're going to talk about yourself. How did you decide to get into medicine and exactly what you're doing with medicine?
I'm a family medicine doctor. And basically, I've wanted to be a doctor my whole life. It's funny because I was just talking about it with my son. He started kindergarten, and I showed him my kindergarten, what I want to be when I grow up, and I put family medicine doctor.
Wow.
So it's just been an aspiration and a dream come true to be here in Texas practicing. Part of the biggest influence was towards family as I grew up with my great-grandparents, my grandparents, my parents, aunts and uncles and cousins. So we cover everyone.
And so where did you grow up?
I grew up in Dallas, Texas.
Dallas, okay. But I know I read in your stuff you went to Texas A&M, so people are whooping now as they hear that from us. So that's exciting. And then how did you connect with UTMB?
So I went to Texas A&M. I majored in nutritional science, molecular and experimental, with a minor in philosophy. And then I went to American University of Antigua, and FIU was a program in Miami. So completed my medical school, and I wanted to come full circle back to Texas. So Texas A&M back for residency. And then UTMB, it's just ever since growing up, you go to Galveston, I'd look at the university, I'd be like, look at that. And my grandpa would say, someday you'll be there. Someday you'll be there. And long and behold, I had the opportunity. And I told them in my interview, you put me in any of the UTMB primary care clinics, I'll be happy.
I love it. I love it. And there you are. So a dream come true. That's a good lesson for everybody. You have a goal to go get with it and you can take care of it. Okay, so today we're talking about alternatives to weight loss programs. And that's mainly what you focus on in your practice?
Yes. So I am board certified in obesity medicine. Just so that I can bring more to the table for my patients. A lot of our medical conditions, doctors say, hey, lose weight, you'll get better. Well, how? You know, that's the biggest thing. So with this board certification, I was able to bring not only medication treatment and then come up with treatment protocols for our patients, catered to different lifestyles as well.
Right. And so there is a struggle now to get the medications. Is that right?
Yes. So basically, Wegovy, one of the medications, it's one of the blockbuster drugs that came out. And initially was covered by most insurances, but it's pretty costly. So a lot of insurances dropped it. So it's really hard for people to get their hands on that medication now.
Right. And so what I read in the article said that there are other medications that you can prescribe now that kind of do the same thing. Is that right?
Not necessarily. They're hitting different modalities
to
address the situation. So, after an assessment with your primary care, sit down and talk. Do you have binge eating disorder? Do you have something with thyroid? Is there something else going on, metabolic disorder? After clearing out all those, then we can decide, okay, there's some oral medications like Kismia, which is phentermine with Topamax. Phentermine's a stimulant, Topamax a migraine medication. So then combined, it's FDA approved as a weight loss adjunct. There's Contrave that's been out for quite a while. It's a combination of two drugs. One is like an addiction medicine type of drug, along with Wellbutrin, which is an antidepressant. And that's an oral as well. Most of the time the insurances don't cover it, so I always just divide up the medications and prescribe it this way.
Right. And are your patients already doing the alternatives, or they've already started that? And how's that going?
So I've been doing those for a couple of years now. So it's not as groundbreaking as Wegovy, which is the blockbuster drug, because we learned so much about how the GLP-1s, which is glucagon-like peptide, has an effect on our weight. And so as far as doing it for particularly comparison, it's like comparing an apple to an orange.
Okay. Okay,
Yeah.
very good. So if somebody is struggling with weight loss issues, sometimes it is, like you said, maybe a thyroid issue, maybe someone going through menopause, things like that, right? And so you look at the whole person. So if someone were to come in, kind of walk us through how you would guide that patient through if this is the first time you're seeing them.
So the first time I kind of advocated to have a 40 minutes when I meet anybody for the first time, because I want to see how you are. How do you like your treatment? Are you a natural person, or do you just want meds, or what's in your life that's hindering you from optimizing who you are? So then we'll get to the bottom of it. I like the fact you brought up menopause, because menopause, I mean, our bodies are trying to hold on to that estrogen. Our fat cells create estrogen. There's an enzyme in our fat cells, so then our body's trying to hold on to that. So then, it's kind of like you're working against going uphill instead of some people just have a straight and narrow path. So it's helping you come up with what's going to work for you.
And so I know that you also talk to people about eating the right foods, right? Exercise, things like that as well, right? You don't just throw medicine their way, right? Or stuff like that.
So in general, we say we practice medicine, right? We're practicing, and it's supposed to be a tool to make your life better. I think you're a good primary care if you don't have to see me too much, because then you're enjoying your life and not thinking about your health. And that's why I think you do the lifestyle along with the diet, and then these are tools to help us.
Now, you're not a surgeon, right? So if someone were to the point of their obesity where they needed bariatric type surgery or something like that, you refer folks, and then is it vice versa? Do they refer folks to you?
So we usually refer people to the bariatric department, especially if you are a good candidate. One of the things is even with bariatrics, insurance coverage is starting to become problematic as well.
Oh, wow.
So always just, if you have a good relationship with your primary care, talk to them, and they're going to be honest with you. Hey, I think you need bariatrics, or hey, let's just try medicine first, and you can't that's why everybody's different. We can't all subjugate everyone to the same cookie cutter textbook regimen.
Right. And I would expect, do you work with all different ages of folks?
I do 12 and older.
12 and older, right?
Yeah.
So, but you do work with older folks.
Yes.
Right? When you mentioned growing up with your grandparents and your parent, all of that, you saw how life changes through all of the different ages and stuff, right? So you're a good candidate for people to come to of all ages.
Yes.
Right.
And I mean, if I do start medication, I have my thought longevity. So I'm like, okay, if I'm going to start you something, I don't want to be at 65, 70 trying to take it off because it's contraindicated in geriatrics. There's a criteria like Beer's criteria for medications we don't want in our elderly. There's different medications we don't give to younger patients because of the long-term effects. So, and that's why it's really important to have a primary care physician kind of helping you navigate through the system.
Right. Very good. So how long have you been doing this practice?
At this practice, it's been 3 years. And I've done 3 years of residency. So 6 years total practice.
Wow. And you're raising a family too. So you're a busy person as well. Very good. So UTMB, when you think about working there and the philosophies there, what are your favorite parts of that? Because all of our listeners will know, we always ask the physicians the same thing. Like, what is it about UTMB that everyone who comes through here, they love working there? They love being a part of it.
I think it's one of the themes is working wonders, right? So working wonders, if everyone who's working there, look at me, for example. I feel like it's my dream to be a family doc. So when you love what you do, you don't feel like you're working, right? And then it's just a fun environment, and each clinic has its own vibe. So each clinic feels like a small town private practice, and being an Aggie, we are all about families. And so at UTMB, I just feel like it's family, and I didn't have to worry about my patients when I had my baby because my colleagues were all up to date with everything, and I didn't have to worry. My patients were all so happy when I came back, it was like half our conversation would be, how's your family? And then I'd be asking, hey, how was your trip? You just went to Europe. How was it? Show me pictures. That's the rule. If you see me, you have to show me pictures. So that's the beauty of UTMB. It doesn't feel like a corporation, you know? And another beautiful thing is it's academic. So I get students, and students keep you fresh, and they keep you reminding you of why you're there, you know? Other institutions, I have friends at other places, and those might be a good fit for those people. So it's about what you're looking for in the place you're at.
I feel like we get that response a lot. UTMB seems to have a holistic approach for all of their medical folks to treat their patients. Now, I think I did read too that you do some of the academics, right? Do you teach in medical school, or what exactly do you do?
I do third-year medical students for their family medicine rotation.
Okay, how's that?
I absolutely love it. The students, UTMB picks some really amazing students. They're all very, very well selected and well-rounded individuals. So I always end up learning something from my student. Just recently, one of my students taught me about AI and ChatGPT, and then I was like, oh, this is great. Teach me more. And then I learned it on myself. And it's, another student was interested in OB, so then she shared her project with me. So it's not necessarily I'm teaching them, they're also teaching me. So it's keeping everything relevant and up to date. And that's what you want in a primary care, because somebody who's kind of like, yeah, we're the jack of all trades, master of none, right? But you want somebody who is, honest and tries their best to learn everything they can for you.
And you're focused on being a good listener to your patients, I bet. I can tell you take each person individually and find out what they need, right?
I know interviews are so weird because it feels like I'm rambling, when we're in an interview. But, when I'm with a patient, I just listen and hear, what they've been through.
What's best for them. Mm-hmm. I love that.
It's always what's best for them, right?
I love that. Now, where can people find you?
I'm at Bay Colony. It's off of 45, right across the UTMB hospital, the League City campus.
Very good. Anything else you want to talk about, or are there things that people should look for if they're experiencing something that it would be a good fit for them to come find out about the weight loss?
My golden rule is, if it costs you money, be careful, right? You want to go to somebody that you trust and evaluates you. There's so many things out there that a lot of my patients are like, oh, I tried this supplement, or I'm paying this much for this. And, honestly, weight loss should be a lifestyle, and maintaining our weight should be a lifelong habit. And you don't pay every day to breathe. You don't pay every day to sleep. So why are you paying extra money for all these things online, like, oh, this diet, this, and that's the biggest thing as a primary care. I want people to know it's about everybody can do something. And then another thing I wanted to share is this BMI. Who created the BMI? It was like a Belgian sociologist in the 18th century. Okay, it wasn't a doctor. It was picked up in the 1970s by American physicians because they started realizing, hey, if your BMI is above this point, you're usually very unhealthy, right? And so then that got picked up. And so even American Medical Association is trying to get away from this BMI metric. And what other thing did the Belgian sociologist forget to include in his population? He used a bunch of German soldiers, right? Females. He forgot all of us women. And just looking at the room right now, we all look very different. And that's the beauty of being in the United States. We all are from different types of genetics. And so then I always ask, how much did your grandparents weigh? How much did you weigh as a baby? What kind of meals did you grow up on? Because if I tell you, if you're a meat and potatoes person and I tell you stop eating meat and potatoes, is that realistic? So that's one of my biggest caveats.
Well, and that's a huge misconception. People talk about the BMI numbers all the time.
Yeah. I don't stress out about the numbers. It's about what's your blood pressure, what's your cholesterol, what's your liver status, and that's another beauty of this these GLP-1s, they're researching so much more because so many people are on them, right? And they found 26% cardiovascular risk reduction.
Wow.
With Wegovy just about a month or two ago, right? We're finding out there was a study done that has been ended early, and studies are only ended early, clinical trials, if it's extremely successful or extremely bad. And it was on chronic kidney disease patients.
So the medicines are proving to work, but you have to do it. I think what I read too in your article was that it's important that you go through a doctor. Yeah, there's all kinds of fads, right, out there. There's all kinds of commercials and ads and things like that. But going through the doctor keeps you the healthiest.
Yeah, because I know a lot of people are starting to try to order this drug off market that's not FDA regulated. And secondly, some of them are not coming from pharmacies here. They're coming from out of country. So if it's coming from out of country, their regulations are not the same as ours. So you don't know if you're getting the true compound or true medication or not. So make sure you go to an FDA regulated route, or you go through a licensed pharmacy and prescribed by a physician or a nurse practitioner or physician assistant.
Very important.
Yeah.
Yeah. Some of the drug simulation stuff now is pretty scary.
Yeah.
Yeah. Wow. So talking about the GLP-1 drugs, will you explain exactly which ones those are? And then if they're not getting covered by insurance right now, or they're out of stock, what you feel like for the future is for those drugs?
GLP-1s are glucagon-like peptide 1 inhibitors. Agonists. Sorry, let me say that again.
Okay.
GLP-1s are glucagon-like peptide agonists. So the FDA-approved one is Wegovy for weight loss, and then it's a pretty older diabetic drug. It's been out since 2005. Ozempic, and then a new one that just came out is Mounjaro last year, and that's a combination of a GLP-1 and a GIP. So what happened is that, like we discussed, the insurance has stopped covering them. But, there's so much research being done. Just like I just talked about, the cardiovascular risk reduction, they're doing a research on non-alcoholic steatohepatitis, which is fatty liver, right? And the research, as it gets published more, then it's going to get FDA approved for more conditions, right? And so then when we have more conditions, then it can be covered by insurance. The second thing is there is research, a demand happening. Ozempic is one of those that is in oral form, and the pharmaceutical company is trying to get that FDA approved for weight loss. Mounjaro is on track to be FDA approved for weight loss. And just remember, so then when more drugs come to market and in competition, it reduces the costs. So I believe that most likely most insurance formularies will reassess and start covering as more drugs come out.
So some of those drugs were originally approved for other things like diabetes and stuff. Is that what you're saying? And now if they change some of their qualifications to weight loss, it could help?
And that's basically how Wegovy came out. Ozempic was noted to have a tremendous amount of weight loss in patients, about 10 to 15% body mass index. So Ozempic's a diabetes drug that did show promise in weight loss, and hence the Novo Nordisk and Eli Lilly started doing more research on it, and Novo Nordisk came out with Wegovy, and Wegovy is the one that is FDA approved for weight loss. It's the exact same drug, semaglutide. One is just stamped okay for weight loss by the FDA.
Wow, okay, that's how that works.
Yeah, yeah. So how it works is glucagon-like peptide is a hormone that's released in our gut. And so then it was helping your pancreas release insulin to your cells, and that's how the sugars came down. But also it helps slow down your gut mobility. So then you're slowly digesting the food. So if you're slowly digesting the food, the sugars don't spike. That's how it was helping the diabetes, and that's how it helped with the weight loss. So another anecdotal that we are noticing as physicians is it's hitting something in our brain that's cutting down the carb cravings. I've had a lot of patients that drink that glass of wine a day, and they're like, Dr. Kalia, I haven't had wine for a month and I don't care now. I'm like, that's pretty groundbreaking. So we'll see what comes out in the next few years. I've had a few patients who had PCOS that have gotten pregnant.
Wow. I read that in the article. That's amazing.
Yeah, it's pretty amazing. So then, it's about people who, want to, obviously pharmaceutical companies, they want to make profit off of things. So then if they can get it covered for other things, they're going to make more profit. And as physicians, we want to treat everything. And this seems like it's treating a lot of metabolic conditions that are related to weight. And if my patients are happy, I'm happy, because then our talks are about their vacations.
Right. And less medications.
Yeah.
Right. Because their blood pressure is lowered. Other things are taken care of.
Oh, I've taken so many patients off of blood pressure meds.
Wow.
After losing about 30, 40 pounds off of blood pressure meds.
Off completely.
Mm-hmm.
Wow. And what about cholesterol stuff? You said you look at that.
Cholesterol, yes. Some patients, the first guideline, and we follow guidelines as doctors. The first thing we always say is when we see cholesterol is, let's do lifestyle modification, Mediterranean diet, exercise, right? We're noticing when people exercise and do the Mediterranean diet, they lose weight, and that's how the cholesterol is getting better. Well, with these drugs, it's helping the motivation, that factor we don't know why it's helping, and it's helping lose weight. So then people are reaching their goal.
Okay, Mediterranean diet. Tell us what that is.
It's low salt, high vegetables, high fiber diet, and less meat.
Okay.
Mm-hmm.
So if people are eating meat, what do you recommend?
To do the healthier versions, things that are rich in omega-3s, omega-6s, like fish, salmon, cut down on the red meats. And I know we're in Texas, so let's just be realistic, okay? We want to be mindful. Mindful eating is the realistic approach. You eat until you feel full. You eat when you're hungry, And that's another thing that I talk to patients about, time-restricted feeding. So, 16 hours we don't eat, and then 8 hours we eat. And if you do that for the first week, you're going to realize how much you eat outside of that 8-hour window. Because, our metabolism is just these hormones that are released in our body, which we're still researching and learning about, right? And so when my patients do it for at least 12 weeks, they do notice a lot more energy and feeling a lot better too.
And is that good for males and females?
Mm-hmm.
The 16-8.
Mm-hmm.
And different ages?
Mm-hmm. Basically, you've heard the whole saying, don't dine after 9.
Mm-hmm.
It kind of follows through that. And if you look at culturally, we weren't supposed to be eating after a certain time. And we just, I'm going to go grab some fast food. Oh, I'm going to go grab this and eat this. And how much of the time, we're in Texas. Whenever I ask, how was your weekend? We went to this place to eat, or where are you going this weekend? This place to eat or this place? Because it's so hot down here. There's not much to do, right? So a lot of our life is kind of around food, but we want to be more mindful of it. So then it's more realistic. Instead of saying that I'm just not going to eat at all. What, you're going to go to a nice restaurant and just sit there and drink water?
Right. But at least the 16 to 8, it seems easy. Seems like you don't have to do a lot of calculating on that.
Yeah.
Just watching the clock.
Yeah, pretty much. And studies are being done at Hopkins in Cleveland. More so, we're seeing results with metabolic conditions like diabetes, thyroid, cholesterol, but like I said, that's why I did the nutrition in undergrad, because I figured it out while I was young. Like, all these primary care conditions are related to what we eat.
Anything else you want to share?
Just, the main goal is to be happy. And so if you're not happy with your health, then go to your primary care doctor. And that usually does help your life.
Because building that relationship with the primary care, most important.
Mm-hmm.
Wonderful. Thank you so much for being here. We appreciate it very much.